for people in the community. So we are super excited that you guys are here today. And I want to say that, you know, the information that we talk about today is hard information and it's a hard topic. But I want to thank you guys for being here today. And one of the biggest takeaways I think that we can do today, if not anything else, is just to say thank you for being here and taking control of your healthcare decisions. That's what we're here today to help you guys do, is to get plans in place for when we need them, right? We make plans for our wedding, we make plans for having babies, we make plans for our education. We make lots of plans for our milestones in life. And this is a milestone that's pretty much guaranteed for everybody in this room. And the other thing too is that we can thank each other for being here to share our energy today with each other. So with that being said, I'm going to let Kat come up and introduce herself and we'll get started. We are also on a virtual call with a few people, so we're going to try to navigate that in the best that we can. Okay.
So I'm kind of the starter, and Jenny's going to come in later and get really in depth in some medical interventions. As she said, she's been a nurse for 20 years with Hospice Austin. I am a former attorney and chaplain, and also a gift presenter, which, as she said, stands for Giving Instructions for Tomorrow. Before I get started, Jenny mentioned that we get a grant from the St. David's Foundation. And so you have evaluations that are sitting on your desk. And I hope you all have figured out the crazy pens. What did I do with my pen? Oh, my pen disappeared off the table. Okay, Jenny's going to demonstrate the pen because it's you twist the bottom, that black part, and hold the top part. It doesn't click at the end, it's a twist. So just so you know that, or else you can't even start the evaluation. So the evaluation helps us because we do have this grant and we want to know what you think. Was it valuable or not? So right now I would ask you to put at the top JCC, or what is the capital? Shalom Austin, or
Capital City Village.
Capital City Village. Either one of those would be fine if you put that on the evaluation on the form, and look at the form with just the one question on it. There are two sides to the evaluation form. The one question is just the starter, and that's what we'd love for you to take a minute to do that now. It just has one question in the middle of the page. And that's kind of, where are you on advanced care planning right now? And of course, we are very hopeful that when I ask you to turn that over at the end of this whole presentation and workshop, that you will have learned something and that you will be able to comment on what your actions you might be taking, what you thought was surprising, just anything like that that would help us and St. David's know, is this a good project for us to be doing, and can we do it better? So that would be great if you could do that. Just do that one question and put the date, which is the 12th, May 12th, and answer that question. Okay. So now I can get into, what is advanced care planning? It is deciding in advance of a medical crisis what medical treatment you would want or would not want, and then telling your loved ones and medical professionals so that you can get those preferences honored. That's really it. And it sounds so simple, but there are kind of a lot of steps to it. I want to emphasize right in the beginning, and I'll probably say it again, there are no right or wrong answers. This is really a discovery about your own values and priorities. How many of you have already a medical power of attorney, a living will? Let's see. Okay. So here's the next question. How many of you have talked to your loved ones specifically about what you want? Still pretty good.
He said he didn't know. I talked to him, but he said he didn't know what he wanted.
He didn't know what he wanted. Yeah.
We talk.
Well, I am hoping, but see, okay, so you mentioned that, and that goes right into my next thing. So as I said, I'm a former attorney. I don't practice anymore, but I had advanced directives. I was real proud of myself. I had my medical power of attorney and my living will, and I put them in a drawer. Yeah, well, they don't do much good in a drawer, and that's what I learned when I was a chaplain at Seton a few years back, and I was really amazed how that piece of paper isn't enough for our loved ones to really be able to have peace and to make decisions that they feel like are good decisions, that this is what you wanted. That piece of paper isn't enough. That's what I learned. And I was pretty surprised. I thought I'd done my job, I'd done my paperwork, and all right, I'm good to go. Well, it wasn't. And one of the cases that really stuck with me, it was during the day. It was a woman in the ICU. She had very advanced cancer. She probably had 20 members of her family there with her, and they were wonderful. And she had advanced directives, and she had chosen comfort care for herself.
I'm sorry, I can hardly hear.
Oh.
Okay.
Okay, I'll speak louder.
Okay.
Okay, so she had chosen comfort care for herself, and on her forms, they said comfort care. She reaches the stage where the doctors are saying there isn't anything more medically we can do. She was unconscious, and the family members, she'd never spoken to them about this, and they did not believe it. They were so uncomfortable. They hadn't processed that she might die. And they would say that to each other. And they were still so hopeful she could do an experimental drug treatment. And there was a lot of talk of that. And yet that time had passed, and they were just having such a hard time accepting it. And that and other incidents made me realize really the biggest part of advanced care planning is not those documents. It is talking to our loved ones about what we want. But I'll tell you, I realized that one of my problems was I didn't know what I wanted because I wasn't in the medical profession. I didn't really know what happened at the end of life, very specifically about what medical interventions, and even my own broad values about it. I didn't know. And so actually that's how I ended up doing what I'm doing now, because I wanted to know better, like, how do I do this, and how do I communicate to my loved ones? So hopefully we're going to, you have the advanced directives, so it's good. I'm not saying that advanced directives are bad. They're good to have, but they're sort of the first thing. And then kind of understanding more what your values are, and then getting those wishes honored by having good communication with your loved ones. That's where we're going today. So, and I think this sometimes surprises people, but I know we'd like to make these decisions for ourselves, right? I would like to. If I need a ventilator, if I need artificial hydration, nutrition, I want to make those decisions for myself. But for most of us, that may not happen. 70% of Americans over 60 and at the end of life, somebody else will be making those medical decisions for them, right? So think of the guilt and uncertainty that they might have if they don't know what to do for it. So that's why we call it the GIFT program. It really is a gift to give our loved ones peace of communicating with them, because it is very likely they will need to make decisions for us. So again, now I'm going to ask you to do a little work, because before we can tell our loved ones what we want, we have to know what we want. So in your packets, I'm going to start with the conversation starter kit. And this is something, it's this right here, this little brochure. It says Conversation Starter Guide, the Conversation Starter Guide. And we provide these things in the packet. There's another thing, a little quiz that Jenny's going to go through with you. And the really good thing about being able to think about this and then write down what you want is that, then you have kind of something you can talk through with your loved ones. Okay, on this value, here's what I think. On this value, here's what I think. And some of them, and we hear this a lot, it's like, I don't know, right? I'm not sure, and here's why I'm not sure. And then they understand your values a little bit more, even with that communication. So we're gonna start with the conversation starter guide. And let's go through some of these. So page 4, we're gonna go through and mark what we're closest to. If you'll see, there are little bubbles on page 4. The first one is, as a patient, I'd like to know only the basics about my condition and my treatment, over to all the details about my condition and my treatment. Well, if mark the bubble that's closest to you, what's closest to your feeling right now. And I see some faces like this. Well, I don't know. And that's why we do this. We start, and you can come back to this too. I've changed my mind, on a couple of these, and that's okay. This just gets us going, thinking about these things. And so it's not a test, no one's grading you, and everyone is going to have a different answer to these questions. So again, as a patient, I'd like to know only the basics about my condition and my treatment, or I want to know all the details about my condition and my treatment. So mark the bubble that's closest to you. When there is a medical decision to be made, I would like my healthcare team to do what they think is best, over to have a say in every healthcare decision. So mark the bubble closest, and there's a bubble right in the middle too, so, The last question on page 4, what are your concerns about medical treatments? I worry that I won't get enough care, over on the left, to I worry that I'll get too much care. And some people ask me, what does that mean? I worry that I'll get too much care. Some people worry that maybe at the end of life, people will keep them on a ventilator or keep giving them artificial nutrition and hydration to keep them alive, and they don't want that. So they would consider that too much, getting too much care. So that's kind of but some people are worried they've had a bad experience in the hospital and they didn't get enough care. They felt ignored, and they're worried that they won't get that care. And these are important things to tell your loved ones about what you want. Up on the top of page 5, if I am diagnosed with a serious illness that could shorten my life, I would prefer to not know how quickly it is progressing, or my doctor's best estimation for how long I have to live. Over to the right, I'd prefer to understand how quickly it is progressing, and my doctor's best estimation for how long I have to live. And it's interesting, people really do have very different ideas of what's going to help them in a disease process, right? Some people feel like, if I know how long I have to live, I'm going to give up and I'm not going to try. And that's going to make my quality of life not very good. I'll be sad all the time. And that's why some people choose, I don't want to know how quickly it's progressing. They think that would be better for them. Some people feel like, I want to know everything about this and how long I might have to live. And some people have told me part of that is I want to know how long I have to be with my family. And I want to make sure that I spend the time with them that I want to spend with them, right? That I have that time and I plan that. So again, there can be very different ideas about what is best for you. If you were seriously ill or near the end of your life, how much medical treatment would you feel was right for you? I would want to try every available treatment to extend my life, even if it's uncomfortable. Or all the way to the right, I would not want to try treatments that impact my quality of life in order to extend my life. And Jenny's going to get a little more into this one Because there are some trade-offs there. How much discomfort, you know, the chemotherapy that might take months and diarrhea and, you know, nausea and depends for me, how much of a chance will that could bring me back to full health, you know, as to whether I would do that or. So, but yes, very, very personal. Where do you prefer to be toward the end of life? I strongly prefer to spend my last days in a healthcare facility, or I strongly prefer to spend my last days at home. This is another really important thing to talk about with your loved ones. Some people really do want to be at home. Some people don't want their family to have the burden of them dying at home. It's very personal. On the next page, page 6. If you weren't able to speak for yourself, would you want people to follow all your wishes or do what they think is best in the moment? I want the people I trust to do exactly what I've said, even if it makes them uncomfortable. Over to, I want the people I trust to do what brings them peace, even if it's different from what I've said. And this brings up some funny discussions, truthfully. And this happened again yesterday. I was doing a workshop and somebody said, I'm going to haunt them if they don't do exactly what I've said. So if you feel that way, you know, you might warn your relative, I'm going to haunt you if you don't do exactly what I say. But just as much, we hear people say, well, I have preferences, but if my son or daughter doesn't feel comfortable with that, I want them to have peace. Am I? Yeah.
Oh, I'm getting the rock star treatment. Okay, I was trying to project it. It's a pretty big room. Thank you so much.
Yes, absolutely.
So yes, and I think that's the last question. Come back to this book when you have time later, but now you have a few things written down. And I think that could be really helpful to go through those value statements with your loved ones about what you would prefer. I do want to, one other thing, mention, all this is about having a conversation. Some people talk about how hard it can be. Like a lot of sons and daughters don't want to talk about this. They say, oh, we're not ready to talk about it. We don't need to talk about that. You're fine. You're fine. You know, we don't need to talk about it. And we hear that a lot, you know, and I think the thing they don't get is you're doing this for them so that they have peace about the decisions they might have to make. And that you're okay talking about this. It's not, you know, it's something you want to talk about. So that you get the end of life you want and so that they have peace about those decisions. Oftentimes, we tell people first, like, okay, if that doesn't work, sometimes we say, okay, start with a memory of someone in your family or someone else's family that had a good or bad end of life, and say, like, remember when Aunt Jane got really sick and she hadn't told anyone what she wanted at the end of life? Her children fought about what to do and everyone was left with bad feelings. I don't want that for my family. I want to talk about it now while I still feel good. So that's something that can kind of broach the subject. Another thing is to write a letter or even do a video, because sometimes people, it's hard to process that a loved one is going to die, you know, and kind of broaching it with them in a way where they get to read the letter and kind of what your wishes are, or look at a video that you've prepared and then have the conversation with them. They just get a little chance to take it in and say, okay, I can talk about this now. Another one that people like a lot is blame it on the Hospice Austin gift project and say that these ladies came and talked to us today and they told me that I needed to talk to someone about who will speak for me when I can't speak for myself, and find that person will you be willing to do that for me? So those are just some tips to get that conversation going. And now I think Jimmy is gonna dig a little deeper with you. Yes,
Can we ask questions or make a statement?
yes,
We've been talking to our children for 10 years and we don't want to hear about it. They know where the documents are. That's about it. Now that we're a little bit more mature, I think they're about ready to listen. But we want to avoid all the confusion that we've had in our family in the past about this.
yeah.
It's been a lot.
Did you all hear that? No,
No, I don't
I think this will reach, but you say your children are now, they've said, no, I want to talk about it. I think you're at the point when they might be able to talk about it.
Not in 10 years.
They've denied it for 10 years, now they're ready, hopefully, and you want to avoid what you've seen happen in your family for other people. Yeah. Yeah, and I hope they're able to talk about it. It's really important, and they know where the documents are, but you haven't had the conversation, so.
And so your kids are obviously right. You're still right.
Thank you, Kat. Capital City Village, Johanna, specifically for bringing us together, as well as Shalom Austin and Matt, for getting all of the technology ready. And so we are very thankful that they organized to get this information to you guys. Okay.
Nope, we're good. Thank you.
So, you know, just because we talk about this today doesn't mean that it's gonna happen anytime soon, because if that was the case, then we talk about winning the lottery and we win the lottery the next day, right? So, once again, you know, just because we're preparing for things doesn't mean that it's talk to you guys about starting the conversation, but I want to make sure that you guys have at least a medical foundation about some of the interventions that you might be faced with if you get into a medical crisis or are at the very end of life. So when we're in that place of a medical emergency or the hospital, that's not the best time to be trying to figure out what the doctors are saying, right? So in your packet of information, Kat, I don't know if you want to go around and maybe help people find their packets, but there is a stapled packet that has the GIVE project on the front. We're going to go through this little packet together, just so you have a reference point. On the first page is some of the information that Kat reviewed, so if you want to go home and share it with your family or review it. A lot of times I go to conferences and I think, wow, that was a great conference, and I get home and I think, and what did we talk about? You actually have something to refer to. The second page is what we're going to start to talk about. And we took the information from this book called Hard Choices for Loving People. It's written by Hank Dunn, who is a chaplain. We took excerpts of this and created it into the shortened version for you guys. Now, if you want a copy of Hard Choices for Loving People, we do have copies in the back. You can easily pick one up if you want to take a full version, if you like to read. But otherwise, we're going to talk about the information that's in this packet of information. So the first thing that I want to talk about is CPR. So CPR is cardiopulmonary resuscitation, and that's also known as like if you want to be a do not resuscitate out in the community, there is a specific order that Kat is going to go through that is the only directive that needs to be signed by a physician in order for it to be complete. And most of the time, people in the community opt to be a do not resuscitate when they are a bit advanced age or have a terminal illness, or maybe several comorbidities or diseases that equate to CPR not being a good choice for them any longer. Or maybe it's just something in their mind that they are at peace with their life and they don't want to be resuscitated. So cardiopulmonary resuscitation out in the community includes chest compressions. So CPR is initiated when we stop breathing or our heart stops beating. And it was designed in the 60s to bring us back to life if we had like an electrocution or a drowning or maybe a sudden death from a heart attack, but our body is in otherwise healthy shape. So CPR hopefully brings us back to a place where we were in our health status. If we are riddled with cancer throughout our body or other disease processes, it's not going to heal us past that, right? That would be amazing. We'd all lay down and say, hey, do CPR on me and I'll feel better. But that's not the case. So at some point in time, CPR may not be a best choice for you. So CPR includes chest compressions. That's like you see it on TV or in the movies, they press on your breastbone to beat your heart right underneath your breastbone. And they have to do that rather rapidly. And it can be pretty brutal because your bones can break, your organs can get punctured by your broken bones and things like that. So it includes chest compressions, some sort of resuscitation, breathing. It also includes pacing with defibrillator pads or shocking with the defibrillator pads, as you may have seen on TV. If it was as glamorous as we see on TV and, you know, they do CPR and the next day we're walking around going to lunch, that would be amazing, but that's not the case. So there are some interesting statistics about CPR. It says about 17% of the patients in the hospital that receive CPR immediately with qualified staff right away, only about 17% survive to be discharged, but they don't mention what type of condition a person is in when they're discharged. They also say that patients with multiple serious medical problems, terminal illnesses, or who cannot live independently survive CPR less than 2% of the time. So those that are living in like a nursing facility, or some sort of assisted living, most likely, CPR is no longer a good option for those people living in that situation. The next intervention that I want to talk about are feeding tubes, artificial nutrition and hydration. So all of these interventions have a place and time that are beneficial for us, right? At some point in time, we either have gotten to a more mature age, and as I age, I keep pushing that up and up. So we're now into our 80s or 90s, maybe pretty soon it'll be 102, right? But we've reached a point where we're at peace with our life. We've had a complete life, and we're ready to go when we're called, or it's our time. So something to consider with all of these interventions are maybe a time trial. So a time trial would be where if you were at a hospital, maybe for a short period of time, you tried one of these interventions to see if it's going to be helpful or not. My mom, I'm her medical power of attorney, and so some of those questions Kat went over with you, I realized I never asked her. Like, I didn't know those things about my mom. Like, does she want me to be in charge of her care, or does she not want me to know what's going on? And so it's important that I knew that. And so I was asking her, I said, well, what if you got a pneumonia? And she said, oh, just let me go. Because she wants to be independent. She does not want to go to nursing home. She does not want to be a burden on anybody. And she said, just let me go. I said, some antibiotics might treat you and you'd be okay. And she said, okay, well, you can try for 3 days. And I said, 3 days? So, we compromised. I got 5 days, it's her choice. I should let her have her choice, right? So there are some of these interventions obviously have a place for a purpose, and then other times they become more burdensome on the body. So that's what's to recognize. So feeding tube can be done several ways. There's a temporary tube that can be placed down your nose, down your throat, into your stomach. That's called an NG tube or a nasogastrial tube. So when that tube is placed, it can be used for medications, hydration, nutrition, and even if somebody is vomiting a lot, it can be used to remove stomach contents so that the person's not nauseated. Sorry, I'm under eating. So an NG tube is a very temporary measure, usually maybe 1 or 2 weeks, not any longer, because it can cause erosion in the throat. Sometimes we do leave it in a little bit longer than that, but most of the times around two weeks is the max on that. So if you need a more permanent solution, they may offer to put in a G tube. And it's a little tube that goes on the outside of your wall straight into your stomach, and it's just this little valve. And it's pretty cool because you can attach to feeding, nutrition, hydration. You can also drain from that if you're really nauseated. And it goes directly into your stomach. So that's called a G tube. Once again, there was a gentleman that they talked about in that little book that I mentioned, and he had some sort of throat cancer, and he thought, this G tube's great. I don't have to go grocery shopping or clean anymore. I just give myself a couple cans of food a day and I'm done and I'm good to go. So, it just is a matter of perspective and whatever is important to you. At times though, sometimes those interventions that seem like, oh, it shouldn't be a problem, can become a burden on the body. The easiest things to see are if our body's not processing those nutrition or the fluids the right way, and they start to cause swelling in the body because they're not staying in either the bloodstream or in where the contents should be, and they cause swelling in the body. The fluid may go out into the lung space and make it hard for a person to breathe, or it may go into the abdominal space and make it harder just for our bodies to do the things that it needs to be doing. So just keep in mind that there is a place and time for those interventions. The other thing that I want to mention is about IV nutrition. So sometimes I think we're all familiar with IVs. That's a little catheter that's placed into our bloodstream, into our veins, and they can do medications, hydration. They can even do nutrition sometimes that way. So the biggest thing about IV fluids to know is if a person is at the very end of their life, then these interventions are probably most likely not going to be of benefit. So they did an interesting research study where they drew blood on a person who was at the end of their life, who had IV fluids and nutrition, and they also drew blood on people who did not. And they found that the people that did not had natural endorphins in our body going on, right? Because we always worry about our loved ones suffering, or that we're starving them or they're dehydrated, but our bodies are so amazing. We do amazing things. And one of those amazing things, as we die, our body releases natural endorphins. So if we intervene and provide nutrition or hydration towards the end of life for our loved one, we're robbing them of that natural pleasure and that natural endorphin that they might be receiving for the process of as they transition out of this world. Do y'all have any questions about tube feedings or hydration? Does it hurt? Does what hurt? The NG tube. So has anybody had an NG tube down placed? I haven't had one myself, but I will say that for everybody that I've seen, they try to pull it out. And sometimes they have to wear mittens or be restrained to the bed. And that is a horrible, horrible thing. But they would try to pull it out if they could. So I don't think it's a comfortable solution, but if it helps somebody improve in a few days, it might be worthwhile. But yeah, I've heard it's not comfortable. Good question. There is some information on page 4 that talks about, once again, the starvation and dehydration information. The next intervention that I want to talk about are ventilators. And I think during the pandemic, there are a lot of things that we learned through the pandemic. One is positive is that a lot of communication can be done over the phone. So Kat's going to go over the directives in a little bit, but one of the most common questions that we get is, well, all of my family they aren't local. Before we would say, well, you want to have somebody local, which is a good idea so that they can get to you and actually visually see you. But if your primary person that you want to assign to make medical decisions doesn't live here, that's okay as long as they can be reached by the phone. So I will say that as one positive thing that we learned from the pandemic is that, they don't always have to be here. And also we can do telehealth or FaceTime, and so the nurses and staff are real good about, doing videos so that people can see your loved one in the hospital too. So there are some positives from the pandemic. In regards to ventilators, ventilators are a machine when our respiratory system stops. So we're having difficulty breathing or we stop breathing. We may be connected to a machine that breathes for us, and that's called a ventilator or respirator. It involves a tube being placed down your throat into your lung space, connected to that machine. Most of the time, a person is sedated, so they can't talk to you because they would try to pull that out, and they need to relax and let their body heal, including their lungs healing. So maybe from a pneumonia or from surgery, ventilators are utilized. If you have a lung condition where your lungs are already puny and not in a good place, getting put on a ventilator is not going to, again, improve your lungs to a better condition. So if you have a lung condition, it's most likely the best idea just to opt for other interventions that may help you breathe easier versus being put on a ventilator. If you need to be on a ventilator for a long period of time, that's usually a short intervention. Once again, the 1 to 2 weeks or so. They may opt to use a tracheostomy, which is a more permanent solution where they surgically place a hole in your trach here and then connect you to your ventilator that way. And that's a more permanent solution. Dialysis is another intervention I want to talk about. Dialysis is where our kidneys fail. And so we need to remove the toxins from our body, and we're connected to a machine that removes those toxins for us. Most of the time it's called hemodialysis, which is where you're connected to a machine and it filters the toxins from your blood. That can either be through a catheter that's a temporary solution out of the top of your chest, or they may implant a more permanent solution in your arm and utilize that. So dialysis is usually 3 days a week, about 4 hours each session, and it becomes a lifelong thing for those with end-stage kidney disease. Sometimes it can be used for a very short period of time to see if our kidneys can recover at the hospital. Another type of dialysis they may offer is called peritoneal dialysis, and that's where they connect a catheter to your abdominal space. And at night when you sleep, you connect yourself to a machine and it washes this fluid through your abdominal cavity and it removes the toxins that way. And that's usually about six hours a night, every night, to remove the toxins from your body. Any questions on those interventions?
How does anybody, people know, and of the people you know of who have gone through it, how do they feel about it?
Well, and so he's asking for people that I know that have gone through this. So we've done this talk for people at the dialysis clinic. It ranges. So we have people that are very healthy that may go every morning, walk in, get dialysis 4 to 8 in the morning, and then go to work all day and be perfectly fine. We have other people that may go to dialysis, get dialysis done, go home, sleep most of the day, maybe wake up at night for a little bit of dinner, sleep the rest of the next day into, have a little bit of lunch, maybe do a few things, eat dinner, go back to bed, and then they go back to dialysis. So it becomes a very different quality of life. Just recently, one of our employees' dads, he was an ER physician. He decided he did 2 years of dialysis and he was still walking and doing things, but he decided that that was not a quality of life that he wanted. His family was devastated, but he opted to say, this is not how I want to live. And it takes usually about a week or two, but it's a very comfortable sort of passing if you die from end-stage renal disease, because you kind of eventually just drift off to sleep. Yeah. The next thing that I want to talk about are antibiotics, which, I realized it was a very interesting thing because I never thought about antibiotics in this sort of way. But pneumonia used to be called the old man's friend, Because dying from pneumonia could be a very peaceful way to go if we opt to do that. So at some point in time, antibiotics may not be an intervention that you decide you want to continue with. Very frequently I see little people who start to get either pneumonias pretty frequently, maybe it's like once every, quarter, then it becomes once every other month, then becomes once a month, or a urinary tract infection, and they're at the hospital each time getting antibiotics, and then they go home for a little while, and then they have to return back to the hospital. At some point in time, they may decide that they don't want to continue with that, and they don't want that IV antibiotic treatment. So I never thought that that would be a very peaceful way to go, because if it's treatable, why wouldn't we treat it? But it's something to consider, especially for like an Alzheimer's, because somebody with an Alzheimer's that may be walking, talking, not knowing what's going on at all, and having somebody totally care for them, they may start to get these infections. And it may be a very peaceful way for them to go versus waiting 10 or 15 years for the Alzheimer's course to finally wear to the end. So antibiotics are something to think about, and it can be a very peaceful way to go. The next page. What's that?
Easiest way to go if you stop taking them or you take too many so that you can.
He's saying it's a peaceful way to go to die from an infection versus, I don't think you can poison, well, I don't know. I don't think you can poison yourself with too many antibiotics. I guess that might, I'm not sure about that. But yeah, opting not to and to die from an infection.
So I'm kind of curious as to why an infection is peaceful. An infection usually causes temperature gradients, makes the nauseous.
Yeah, so you may have some symptoms from dying from an infection, but it's a short period of time that you would last. So, anywhere from days to weeks, versus with like an Alzheimer's dementia, you could last 10 to 15 years with that condition before you pass from that condition.
Okay.
The next two things that I want to talk about, did you Rick?
Minute you're not gonna try medicine, so you're gonna have antibiotics.
That's good. I don't have a clock around. Does anybody know what?
12:21.
Okay, just a few more minutes. We're gonna have a little break. We're gonna come back and take a quiz. I know it's open book. Y'all can share answers. It's no pressure. But we're gonna take a little break. Let's just stretch our legs. And then we'll talk about directives after we take our little quiz. So the next two things that I want to kind of talk about briefly, and if you have more questions about either services, feel free to come up and ask me for sure. So palliative and hospice care, we get a lot of questions about what are those two services and what does it mean for either one. So palliative care, both services are available when a family wants to focus on quality of life and symptom management. Palliative care is usually when somebody has serious illnesses or chronic conditions, as well as symptoms that are affecting their quality of life. So if you have, like say, a cancer and diabetes and hypertension and hypothyroidism and arthritis, right? The list can go on and on, but you may wonder how each intervention for either of any of those disease processes affect one another, or what it might look like on the impact of your life. And so palliative care will come in and look at a person as a whole being. And it's usually a team of people. So it's usually a doctor, nurse practitioner, a nurse, and a social worker, at least those people as a team, as well as other ancillary supports, like maybe sometimes chaplain services, occupational therapy, physical therapy, massage therapists, that may be part of a palliative care team. And so they look at your whole being, as well as like what social supports do you have? Do you have a mode of transportation to get to doctor's appointments, to dialysis? Do you have dialysis and cancer and trying to do chemo and what those interventions may look like? Do you have chronic back pain and how can we help your back pain? So they'll look at you as a whole being to treat your symptoms and talk about your quality of life and what's important to you. So palliative care is paid for by Medicare, Medicaid, insurance companies. We have a group called Austin Palliative Care. There's a brochure in your booklet that talks about the services available. They also have a grant from St. David's Foundation and provide services into the community. So if your insurance doesn't cover palliative care, they may be able to offer services for you. So be sure to look at palliative care. Palliative care is like a specialty, like oncology or cardiology or, renal. So it is a specialty that supports all of those other doctors in your primary care, in your care. It's usually a service that can go to you. There are some office-based services, but it's usually a service that can go to you as a home-based service. Hospice care is similar in some aspects, but there has to be a diagnosis from a physician that says, we wouldn't be surprised if Melody was not with us in 6 months. So if you ever get to a point where your loved one or your family or your friends, you think, gosh, they've been in the hospital so many times, they lost weight now. I wouldn't be surprised if they weren't with us in 6 months. That might be a time to call hospice in. A lot of times hospice people are scared of that word or that service because it means that that person is going to die soon. Well, we do our best work when we have months of time with a family. And sometimes we graduate people from hospice. So just know that just because you start hospice doesn't mean that you're going to die right away. And having services and research has shown that people on hospice have a better quality of life and can live longer too with hospice care versus without. So hospice services are once again not a place, but it is a service that goes to you wherever you are. That could be in the hospital, that could be in a nursing home. Home base is where most of our clients are. Homeless, we take care of the homeless population. Jail, I don't think any of y'all are going to jail anytime soon, but we can see you there if you're dying. So it once again is a team-based approach. There is a doctor, nurse practitioner, nurse, social worker, chaplain, aides available to help with the bath, volunteers that want to help reduce family stress. And they focus on symptom management, helping you feel the best that you can, preventing hospitalizations, or if a person doesn't ever want to see the inside of a hospital again, that might be a time that we for sure want to get hospice on board. Other things that can be included are equipment needs to keep you independent, like maybe a mechanical bed or bedside commode, shower chair. All of those things are tools to keep us independent. Supplies that we may need for care, medications that are related to symptom management and our diseases. You may see a decrease in some of the co-pays. And then we have an on-call nurse available 24 hours a day. So if on the weekends at 3 o'clock in the morning, there's an issue that comes up, instead of trying to call, I don't know if any of y'all have tried to call 911, but it is, I've had families wait 46 minutes for somebody to answer the phone just to be dispatched. So I tried to call at a patient's house. I waited 11 minutes. Thankfully, we got everything resolved. I didn't have to wait any longer, but it is pretty rough out there right now. Hospice services provide a 24-hour nurse available at the touch of the phone call. So we represent Hospice Austin. There are a lot of hospice choices in the community. I will say that Hospice Austin is a nonprofit. That's why I continue to work for who I do. What does that mean? That means what profits we do generate, we put back out into services for the community. We also are one of the only hospices that has an inpatient facility called Christopher House. Christopher House can be used for symptom management or for very end of life stay. And if you have any other questions about either services, please feel free to come up and ask. Mark?
We had a friend that probably outlived his projected lifespan by about 3 years.
Yeah.
It was in hospice the whole time, and he loved it. And he told us, y'all brought him oxygen in the middle of the night,
Yeah.
which he of course, he was thrilled, but that's pretty impressive.
Yeah, Mark saying there was a gentleman who outlived his expectancy by 3 years, which there was another gentleman that was 102, was on services for 3 years. He would get dressed up for his hospice team that came by to see him. He didn't have any family around. We filled his little squirrel feeders and his bird feeders and just checked on him, and he did well. I mean, he thrived with care. We finally graduated him at 102, and then he had just without services, he just didn't do well. And they called us back about a month later, and then he didn't last very long after that. But yeah, we don't have to, physicians don't necessarily know, right? They're doing their best guess, but we can always outlive whatever they predict.
What does graduating mean?
He asked, what does graduating mean? Well, that just means your hospice services stop and you graduate from hospice until you need us again, and then you just call us back. Yeah.
Why would you graduate? What would be the symptoms of graduation?
He's asking, what would be the symptoms to graduate from hospice? Well, you gain weight, you improve, you're no longer, a doctor looks at you and says, I don't think you're gonna die in 6 months, you're doing really well. And so that's how somebody can graduate from hospice services, or they can stop hospice if maybe you're doing well or you decide that that's a good point. So with hospice, you cannot pursue aggressive medical interventions. With palliative care, you can. So when you start hospice, you're at a point where you're not doing diagnostic evaluations or any aggressive sorts of chemo, therapies, dialysis, those sorts of interventions. So glad you brought that up.
Waiting list to get hospice care?
No, and so he asked if there's a waiting list for hospice care. No, so most of the hospice agencies will respond very rapidly. So within, hours, and we can be out, we can be delivering equipment and getting medications and things as soon as the same day. We are very fast on our feet. Yes, me.
How do the various hospice organizations differ?
Yeah, because that's gonna be where the agency is different. So once again, hospice often is one of the only nonprofits in the area. The others are for-profits, so that means that they turn their profits back out to their stakeholders. Hospice often is a very gray, I say gray hospice, meaning we look at each person individually and we talk about what's important to them, and we may allow interventions that other hospices would not. Meaning, like say, your child is graduating May 26th and you need blood transfusions to keep you alive until then. We would allow blood transfusions to that end goal. Other hospices would say, no, that's life sustaining. We're not going to do that. Other things, we have Christopher House. We have an on-call staff. We have our own doctors that specialize in hospice and palliative care. So there is a long list of different things that you can look at when you're interviewing hospices. Also, there is a website for Medicare called Hospice, what is that? Do you know the hospice website? There is a hospice website that Hospice Compare, that compares all the hospices in the agency from patients. And so there's a survey that goes out and people can respond. So you can actually compare hospices from one another. Yeah. Yes.
Positive note, my husband passed at Christopher House. And he was transferred there directly from the city. He had metastatic prostate cancer, many situations, it was something else, it was kidney failure that got him. So he was transferred there immediately, and it was a pleasant experience. And they did at the end, and I'm so glad that you explained that, because my son was in boot camp in the Marines at Camp Pendleton, and a lot of paperwork. But anyway, the Red Cross got him home on compassionate leave, and Christopher House allowed us respiratory assistance, with just oxygen.
Yeah.
And it allowed him to leave it for the last hour of his life. My son. But yeah, it was, and it was it was more like a home. You know, if you had to do something, because sometimes you're in a rough situation and you think, hospital home. But anyway, it was good.
Oh, thank you so much for, she was just talking about her husband. Her husband passed at Christopher House, and it was a good experience. And that Christopher House is like a home-like setting, which it is. I'm glad.
The situation that she brought up would end up happening if the person had been at home instead of at Christopher House.
So she's asking if the patient was at home versus Christopher House. It's hard to say. I mean, we support people at home through their final hours. So it just really depends on what the person is needing. I'm not sure the situation, but we absolutely positively support people at home. And they can have oxygen at home. I don't know if he had a little bit more than that or not, but
He was in a coma already, but, yeah, it's important for my son.
yeah. Well, okay, Pat and I are here. We're gonna give you
12:34.
10 minutes to stand up, stretch, say hello to each other, use the restrooms in the hallway, and then we'll come back at 12:45. And take our little quiz together.
You can just leave it on. It won't come up anything. So good. Yeah, so you were, I think, we were able to see your score and hear you great. So.
Email text. And I asked them,
Oh, sure. Oh, yeah.
yeah.
Yeah. Absolutely. Sorry about that.
I saw that, your wife happy, also.
Yes.
My wife didn't make it. But they do.
It's probably good for you.
I didn't, but that's okay. No.
Well.
Thank you.
I'm sorry.
No, that's okay.
Because I know that.
That's okay. It's, I mean, I didn't think, I'm glad I'm.
Okay. I'm gonna get with Jenny because, you know, the packets of information we can get extras of.
Great.
But we're gonna just go through a little medical proxy quiz together, just to kind of think about some of these scenarios together. And put some of this information into practice-ish. So we're on page 7. Kat, did you know we have page numbers on our books? It's very exciting. Yeah, you didn't do it? No, I didn't either. Surely did. That's good. Okay, so we're still in our little packet. We are on page 7. And let's just go through this, and then I'm gonna turn it over to Kat, who's gonna talk about documenting our wishes and values in our directives, which I know most of you guys already have. So we'll probably breeze through that rather quickly, but at least bring up some good pointers, and hopefully you can take some takeaways home from that information. So on page 7, number 1, personal medical preferences. It's a complete questionnaire by yourself. Well, all right, but make it your own choices, but we can share it. So number 1 says, imagine you had Alzheimer's disease and it had progressed to a point where you could not recognize or converse with your loved ones. When spoon feeding was no longer possible, would you want to be fed by a tube into your stomach? Yes, no, or uncertain. Number 2 says, which of the following do you fear most at the end of life? A, being in pain. B, losing the ability to think. C, being a financial burden on loved ones. Or I had D, all the above. Number 3, imagine that you're seriously ill and the doctors are recommending chemotherapy. Chemotherapy has severe side effects such as pain, nausea, vomiting, and weakness that can last for a couple months. Would you be willing to endure the side effects if the chance of regaining your current health would be less than 1%? Yes, no, or uncertain. That's the number rules. I'm like, well, maybe 50%. 75, I don't know. Number 4, in the same scenario, suppose your condition is clearly terminal, but chemotherapy might give you an additional 6 months of life. Would you want the chemotherapy even though it has severe side effects such as pain, nausea, vomiting, and weakness? Yes, no, or uncertain.
I was wondering, I'm sure everything is subjective, every situation is for the case. But when you're like a dialysis, you were making that statement. When you're in chemo, you have your treatments, but doesn't it control your life at that point? Because you're either often recovering from that, or you can't participate in family functions and stuff because you're obligated. I mean, the quality of life is affected, isn't it, under the chemo?
Yeah, chemo can be different for everybody. I mean, I don't know if anybody's had chemo in here. I personally haven't. But it can vary from person to person. Yeah. Okay, 5. If you were terminally ill with a condition that caused much pain, would you want to be sedated, even to the point of unconsciousness, if it were necessary to control your pain? Yes, no, or uncertain. Now, also, if we could tell our loved ones what we want, right, that's what we're gonna do. But like Kat mentioned, those over 60, only 30% of us will be able to make our own decisions at the end of life. So that's only 3 out of 10 of us in here that will actually be able to verbalize what we want at the end of life. 7 of us will be having somebody else will be making those medical decisions for us. So that's why it's important that we tell them what we want. Now, I know everybody's under 60 in here, so it's not any worries. The stats are a little bit better, but.
So what are the statistics for people under 60 and that's a great way to put this?
I don't know. I guess I don't know, if research, lots of research needs to be done, especially after COVID. I don't know what the stats are under 60. Okay, number 6, imagine you have moderate dementia causing mental confusion. Half the time you recognize and interact with family and friends on a simple level, but you have circulation problems too, and one leg has been amputated because of developed gangrene. Now your other leg gets gangrene and the doctors recommend the amputation because it could be fatal. Would you want the operation? Yes, no, or uncertain? And I've met these people. These are all true scenarios, especially at Dulcie Old Brackenridge. I mean, these are true scenarios. Number 7, is it more important for you to A, have specific treatment preferences followed at the end of life, even if members of your family or friends disagree, or have your family and friends all in agreement and come comfortable with whatever decisions made? A, have specific preferences followed, even if there's a disagreement. B, have family and friends all in agreement, or C, I'm uncertain. And in the 20 years I've been doing hospice care, I did meet one lady whose daughter was making decisions that were not what her choices were, and I knew what her choices were, and I asked her, on the side, well, that's not what you want, is that okay? And she said, that's okay, let my daughter make the decisions, it'll be all right. And so, that was her choice. So everybody's different. Number 8, imagine that you're physically frail and you need help with most of your daily activities, dressing, bathing, eating, going to the bathroom. You live in a nursing home, your mind is fairly clear and capable most of the time, but you've had pneumonia or a lung infection 4 times this last year. Each time you had to be hospitalized for several days and given antibiotics through an IV. Next time you get pneumonia, do you want aggressive antibiotic treatment again, or just comfort care until death comes? Oh, see, I guess I was pre-emptying you guys for this question. A, antibiotic treatment, B, comfort care, or C, I'm uncertain. And everybody's different. Maybe we say, try 10 times. I mean, who knows until we're actually in that event. 9, imagine that you're in a permanent coma, you're dependent on a tube inserted in your stomach for nutrition and hydration. Would it be important to you that decisions about your treatment be guided by particular religious beliefs or spiritual values that you hold? Yes, no, or I'm uncertain. And then the last one, it says, if your heart, kidneys, pancreas, lungs, and liver could all be used in transplant operations to save other lives, would you want to donate them at death? Yeah. There's different things that we can do with our bodies as we age. I don't know, Kat, do you know the organ donation age? I think the biggest thing is, bodies can be donated to science too, other than just saving people's lives. So we can learn from people's bodies. That's one way is to be donations.
As far as donating
Organs?
your body, it's a long, it's not something that can be done. It's something you have to initiate. It well in advance.
Yeah, so it depends, like if it's a car accident or something like that, if a person's organs are viable, they will ask family if organs can be used to save others. So that could be something that's rather quick. Other than that, yeah, you do have to do planning. But there are organizations that will do body donations. There's various things we can do with our bodies. Have y'all ever heard of a body farm?
Yes.
I didn't know about body farms. Body farms are a place where you can donate your body and they use it for forensic science to solve crimes later on. So they may put a person in water and see what happens to their body in a couple days or out in the field. But anyways, they can do various things on this body farm. I didn't know about body farms.
You haven't driven by San Marcos?
Yeah.
I've driven,
83
I've never seen it as a kid. Really? Versus you can smell it.
Texas State.
Really?
Yeah, the body farm.
I
We're sponsoring a friend who signed up
Oh, really?
Who's strange records?
A spot, you're sponsoring the night?
Well, he went there, it was done.
Oh,
He signed all the papers.
can you go visit? him? That's weird.
So,
Okay, so your quiz is done, everybody got an A. Kat, we're gonna turn you guys back to Kat, and she's gonna talk about, let's document our preferences and make sure that our wishes are good.
Okay. Yes, we're gonna document, and since so many of you have documented your advanced directives already. And the 3 advanced directives I'm going to go over are the medical power of attorney. The directive to physicians and family or surrogates, I just call it the living will, because that's so much easier. And then the out of hospital do not resuscitate order, and you have those 3 directives in your packet. Now, I know you guys already have directives done. I'd say after this, the first thing you should do is make sure in your directives that all the phone numbers are still correct, right? Because that won't do you much good if the phone number is not correct. Second is whether you do some new directives or you use those ones you already have you made copies and given them to your loved ones, especially your medical power of attorney, but also other loved ones who might be called, and then they'll know who it is and be able to pass that information on. Yeah, so the copies, and then copies to your doctor. So copies are perfectly legal. People get hung up on the original. In fact, there's a place on the form that says, where is the original kept? And you don't even have to fill that out. It doesn't matter. The copies are good. The thing to remember is, you can't cross out. So if a phone number is not right, you're gonna need to do a new directive. And which is easy because you just need a couple witnesses, and I'm gonna go over that. Ginny and I can be witnesses today. If you need to do one, we can stay after and sign and be witnesses. But you don't need to have a notary, although there is in the medical power of attorney, there's a place for a notary. If you want to do that, that's fine, but you only need two witnesses. So you can change the form pretty easily. And then you've got to remember then to make the new copies, right? And the copy with the latest date is what's going to be good. I know Jenny told me a story of they had a family with there were 9 medical power of attorneys, right, Jenny? And they had to go through and see which date was the most recent date. So, but you do want to get the new one out there if you've made changes. Okay, so I wanted to start with that because I know you all have some, but if you didn't have one, make sure that in the medical power of attorney, that's the form we're going to go over first. The person you appoint must be at least 18 years old. It can't be your physician or an employee of your home health agency, hospital, nursing facility, or residential care facility. So that's just sort of the minimum requirement for your medical power of attorney. I do want to say a few words about, okay, but what makes a good medical power of attorney, right? What are the qualities I should look for? I think a lot of people just write someone down that they think it should be. But make sure that that person is available, and Jenny mentioned this too, like phone call is okay, but they should pick up their phone. You know, if you have someone in your family, a son or daughter, who travels a lot, who's out of the country, who doesn't pick up their phone because they're working a lot, you know, maybe they're not the best medical power of attorney for you. You just want to make sure they'll be know they're on call to pick up the phone to help you if you need that help. They need to speak for you. The next thing is, will they be able to follow your instructions? So that's kind of a tough one. And some people don't even ask their medical power of attorney, will you be the medical power of attorney? Will you be able to follow these instructions that I have for you? And there are lots of reasons why people might not be able to follow your instructions. They may love you so much, but they may say, my values are so different. I could not do that for you. please ask someone else, and that does happen. So make sure you ask them. The other reason they might not be able to, and this happened in my family, my sister is a doctor, and she's super smart and great. But I did not ask her because I thought it would be too much of an emotional burden for her if she was the one that had to let me go, because we had a brother who had a brain tumor when he was 6, I was 12, and he had a really rough life and died when he was in his 30s. And I don't think my sister, I don't think she could let me go that easily. There was a lot of emotion and sadness around my brother, John. And so I told her, it's like, I think you're amazing. I want you to be involved. I want you to be there if you can be there at my side. But I've decided that I don't want to burden you with that. So that's something to think about too. Are they going to be emotionally able to follow your instructions? The other thing is, will they be able to advocate for your wishes? You know, it can be an emotional time, doctors, nurses, all this information coming at them. Will they be able to advocate for your wishes in that moment? And ask them that too. You know, will you feel comfortable with this? It could be a little, you know, difficult in those circumstances. So those are the things to think about yourself, also to talk about with your medical power of attorney. So now on the form itself, if you look at the form, there's a place, okay, at the top you say I, and then you put your name, and then it says appoint, and then there's a colon. And then when it says name and address, that's the name and address of the person you're appointing. Okay, that's your first choice. And then there's the phone number, and then you go down and it says limitations on the decision-making authority. Most people don't put limitations on their medical power of attorney. They want the medical power of attorney to be able to do what's necessary in the moment, closest to your values and priorities that they can get for that situation. Some people though, and I have known a person for religious reasons who did not want blood products. And so they did not want their medical power of attorney to give blood products under any circumstances, even if it meant that they would die. They were okay with that. And so that may be a limitation that, you know, makes sense for someone. It's like, under no circumstances will you do this thing. But like I said, most people actually leave that blank. Designation of an alternate agent. This is really a smart thing to do because people are busy, can't answer the phone, and an emergency happens, and it's really smart to put a first alternate, especially, and even a second alternate if you have those. So that's a good plan. Again, I said the original of the document, if you want to put that in, but it's not necessary. And then the following individuals or institutions have signed copies. Definitely give the signed copies to those institutions. That's the biggest important thing. Whether you write who has it or not is not that important, right? But you definitely should give the copy to the institution. Oh, they mean like medical institution, doctor's offices, a hospital.
If you're taken by an ambulance and you're unconscious, you don't know what hospital you're going to. So don't you need to?
Right. Well, no, this is if you write this down on this form, your medical power of attorney will then see that institution has this document. But really, your medical power of attorney should have the document. And in fact, as I said, make copies to them. In this day and age now, what a lot of people do is take pictures of their documents and then send them by email, so that your medical power of attorney always has that with them on their phone, a copy on their phone. There's also on Apple phone something called It's My Directives, right, Jenny? On the Apple phone, you can get an app, My Directives, and you can have your directives in there, and then they'll come up too on your phone. And I would say there's an emergency contact person on your phone. So let's say you were in a car accident, really smart to have that emergency contact person listed with their phone number, because hopefully that's a medical power of attorney that then, and that comes up on your phone. You don't have to have a password for that. So like an EMS person could look on your phone and see, this is the person I need to call. Ginny wants to say something.
If anybody needs help trying to figure that out, come see us afterwards. We can try to help.
Thank you.
Along that line, what if you did, because you had a procedure 5 years ago in a hospital, let's say you were in St. David's or a Delaware hospital, how do you know it still exists? Because I can never find any information.
I was told that St. David's doesn't keep them on file. Seton does keep them on file, but St. David's doesn't. And so really your medical power of attorneys again should just have them for the next time that they're called, that somebody needs to have that document there. Yeah.
I've been in St. David's as a patient and as a worker many times. And yes, I have to take a copy every single time.
She's saying she has to take a copy every single time to St. David's. Yeah. Yeah, okay.
I'm sorry. Maybe this is for after the discussion, but I guess a lot of this is very timely, especially with maybe changes in societal viewpoints. But are there instances, or is it only on TV, where a hospital is so much in a quandary, legally or otherwise, and your wishes may not be followed? I'm not saying something weird like being, buried with a Cadillac, let somebody wish to do that.
Well, it's interesting. They are supposed to follow your wishes. There is something that states in the law that a doctor who says I can't follow these wishes is supposed to then make it available for you to transfer somewhere where they would follow your wishes. It gets pretty complicated. My understanding is that they will follow your wishes, and the problem is actually more with like sons, daughters not agreeing, right? And then it becomes more complicated. There are ethical committees that are sometimes called, but if you have filled out a medical power of attorney, and the medical power of attorney, you can only list one person. I should have said that. Some people say, oh, can I list 2 people as my medical power of attorney? No, because this is why you want to avoid this conflict. One person gets to make the decision and the doctor can, and they can rely on that. Okay, so only list one person, and if you have the medical power of attorney, they should be able to follow it. A lot of problems come up if people don't, because the way that, like, if you didn't have a medical power of attorney, then the law says that first they'd ask your spouse what you would want. Second, it would be an available adult child. Then it would be parents, and then next of kin. So the available adult child is the problem, right? And a lot of times, because there could be multiple available adult children who all have a different idea of what's good for you and what you would want. And then it can get complicated. So I'm glad you brought that up, because it just gives you another reason to fill this form out. Yes.
So I'm in the process of making my will, and that young attorney told me that I could have both my medical field children as a joint medical POA.
The attorney told you they could be a joint POA?
Because they're both, one's a paramedic and the other one's on his way to PA school.
Yes, I don't doubt that they both be qualified. What I don't understand about that is it doesn't create clarity for the person that needs, the doctor, the hospital that needs to make a decision about what to do in this instance. So what I would do in that instance, personally, I would make one of them the medical power of attorney and let them know, I had to choose. I love you both, and I think you both be great, but one is going to be the medical power of attorney and the other is going to be the alternate. And truthfully, probably there won't be a conflict and it will be fine. They'll both come to some agreement, right? But you would not want, I would not want my kids to then be in conflict about what to do. you know, and so giving one the right to make the decision and the other the alternate. And if the alternate's the only one that's available and the medical power of attorney wasn't available, then that person would choose. So, yeah, I hope that's helpful. Do you have something to comment on that,
Yeah.
John?
Seen at the hospital where they have multiple children lumped as primary, and that's okay. I mean, as long as they're talking, it does not make it clear, but, you know, usually there's not, I haven't had conflicts. I had somebody that had 4 just the other day, 4
Well,
children, but I mean, they were all together. But it doesn't. really-
but sometimes they're not, and I can't imagine then what does the document do? How does it help if they're not? So I'm thinking about the hospital and the doctor who needs an answer, and being able to rely on that answer. Sorry, yes?
We didn't have a document, and my sister and I didn't agree, which ended up probably having my mother in intensive care for at least 2 weeks beyond what she needed, you know, it was a mess.
Yeah, it was a mess. So in your case, it would have to have had a document and some clarity about who decides that would have been helpful. It
My
sounds like.
sister was fine.
And what?
Oh,
Sister was wrong. Okay, yes, okay. Okay, so that, let me see, did I get it? The notarized or 2 witnesses, and the witnesses, the first witness can't be the appointed power of attorney, can't be someone related to you, can't be entitled to a portion of your estate, your position, an employee of your position, or a healthcare facility employee that provides direct care to you. And it says that it's just the first witness that can't be one of those people, but I just make sure that those witnesses unrelated to you and not gonna inherit all that stuff, because it's just cleaner. And again, if you want to change the document, you need to create a new one, don't cross out. Okay, so that's the medical power of attorney. No one asked some good questions about it. I hope that was helpful. Are we ready to move on to the directive? Oh, no, one more question.
Initiate a new document, if you cross out, you can't just initial it like on a.
No, they ask you to do a new document. Yeah, but again, you just need 2 witnesses. So it's not like you have to go to the notary, you're fine, you know, but yeah, they really prefer that you do a new one. Okay, so the directive to physicians and family or surrogates, which we mostly call a living will. I've written all over mine, but it's this one. Made some highlights there. Okay, so let's talk about this, and did everyone have this one too? I know you mostly have your medical power of attorney. Do you have this directive to physicians and family or surrogates, the living will? Yes? Seeing some nods, okay, well, let's see if this changes your decision about anything, or if you were right on. Okay, so at the top of the document, it says, this is an important legal document known as an advance directive. It is designed to help you communicate your wishes about medical treatment at some time in the future when you are unable to make your wishes known because of illness or injury. So again, with this document and also with the medical power of attorney, let me emphasize, if you can speak for yourself, you get to decide. You always get to decide. It doesn't matter what you've said here. If you can say, and when you say something, it can be totally against what you've written here. That's okay. If you can say for yourself, you get to say for yourself. So I just want to reassure you about that. But this is only if you can't speak for yourself. This gives a directive to your loved ones and to the doctors about what you might want in a situation where you can't speak for yourself. So when you go down to the directive, it says, you put your name. And then I direct that the following treatment preferences be honored. And there are 2 scenarios here, and I'm just going to go over these 2 scenarios. The 2 choices are the same under each one, but the scenarios are a little different, and you might want something, you might choose differently about what you want. So the first scenario is, if in the judgment of my physician, I am suffering with a terminal condition from which I am expected to die within 6 months, even with available life-sustaining treatment. So that's where you are right now. The physician says, I believe you will die of this terminal condition within 6 months, even if we give you life-sustaining treatment. Okay, so the choices are, I request that all treatments other than those needed to keep me comfortable be discontinued or withheld, and my physician allow me to die as gently as possible. So that's the comfort care choice. Or I request that I be kept alive in this terminal condition using available life-sustaining treatment. And you would initial one of those lines on your decision. The next scenario below that is, if in the judgment of my physician, I'm suffering with an irreversible condition, so that I cannot care for myself or make decisions for myself, and am expected to die without life-sustaining treatment. And then the same two choices. Do I want just the comfort care to die as gently as possible? Or do I want to be kept alive in this irreversible condition using available life-sustaining treatment? And I usually like to give a couple of examples on this one. One example is Alzheimer's. So you're at the stage of Alzheimer's, and this is important. It says you have Alzheimer's, which is an irreversible condition, and you cannot care for yourself at this point, and you cannot make decisions for yourself at this point in the disease process. And you would be expected to die without life-sustaining treatment. So with the life-sustaining treatment, you could live for 10, 12, 15 years in this condition where you can't care for yourself, you can't make decisions for yourself. But if you get the life-sustaining treatment, the medical interventions that Jenny talked about, then you could live for a very long time in that condition. Another one might be in a coma. If you're in a coma and the doctors have said this is irreversible, you're in an irreversible coma and you can't care for yourself, you can't make decisions for yourself. You would die without the life-sustaining treatment, but with life-sustaining treatment, you could live for years in that condition. So those are a couple of examples to think about when making those decisions. At the top of the next page, page 2, you'll say additional requests. And so you could list particular treatments in the space that you do or do not want in specific circumstances, like artificial nutrition and hydration, IV antibiotics, all those kinds of things. If you're really, really clear what you want, you could put that there, or if you want like a trial period for something, you could put that there. And some people feel like, well, I'm not going to put anything because every circumstance is so different. And I've already talked to my medical power of attorney and my other loved ones, and I want them to be able to choose for that particular circumstance. It's hard to write everything you might want in that little space. But again, they have an option for you to do that right there on the form. So I would say down below that where it says, if you do not have a medical power of attorney, don't fill that in because you already have a medical power of attorney form. So don't complicate things by putting your medical power of attorneys here. And because again, if you create a new medical power of attorney, then they could be different from the ones listed here. So I leave those blank. And then this one doesn't even have a place for a notary. It just requires the 2 witnesses. Fine. So that is the directive to physicians and family or surrogates. Do y'all have questions about that? Or no? All right. We'll go on to the out of hospital do not resuscitate form. And this is an order. So this one is very different. I want to make clear that if the documents we just talked about, everyone over 18 should ideally have one, right? This next one, the out of hospital do not resuscitate order, not everyone's ready for this. I don't have this. And I like to be clear. I give an example, it's kind of harsh, but it's good to think about. Once this is done, it's the doctor's order, so we could like help you fill this out today, and if we did, then you would still need to get the physician to sign off on it as well. Okay, and then it would become an order that would go into place right then, like, and you are saying at that moment, this form's in place, I'm ready to go, no matter what happens. So for instance, if someone came in here and somebody choked on a Jason's cookie, and you're laying on the floor and, well, let's just say we're all terrible and the nurse wasn't here and we couldn't get that cookie out and you did lose consciousness and your heart stopped beating. EMS comes right then and your form is right there, all filled out, your DNR, and they won't resuscitate you. Would you be ready for that at this point? So I am not ready for that. I'm thinking the rest of me is still pretty good, and I want them to do the DNR. Because again, Jane said, it happens surrounding electrocution. You know, we might have some good time left in us. Yes. The out of hospital part means that this is good, like I said, like in EMS, if you're not in the hospital, you're out in the community, you're at your home. The interesting thing is out of hospital is also in the emergency room. Because until you're admitted to the hospital, this form still goes, still good. Once you're admitted to the hospital, they would ask you, or if you're unconscious, you're going to the power of attorney, what do you like? What is your code? Do you want to be DNR at that point? And that's a separate thing that they have to establish when you're admitted in the hospital. And I'm glad you asked that too, because it's also, where do you put this? This is a very picky form. So if you do want this, and by the way, most people filling this out are like, you know, at least my age, and I know that this is the tiniest writing I have ever seen on a form. It's like crazy. But it requires everybody to sign twice, including the doctor. And so it's just very picky to fill out. When you do copy it, copy is good, but they want both sides of the form. And we've heard that sometimes they'll take it without that, but you're supposed to have both sides of the form copied. And where to put it or how to let people know your DNR. So a couple things, when you're in your house, a lot of people put them on the back of the door. And I know some people were putting them in the freezer, which I think would also work, but really EMS has told us, it's like, well, we come right in the front door and we go to the person, we don't go through the kitchen usually. So it's probably good to keep it in a place where if somebody called, your envelope of advanced directives, including the DNR, it's right there, that they can see that. Another thing is that, like, if you're out in the community and you have filled out a form and you want a device, they have a necklace, kind of a medallion, I should say, or a bracelet. And the Texas Department of Health has a website where you can go on and they have a couple of medical device. Do you have examples, Jenny? I think I do somewhere, but anyway, they have 2 medical device companies, maybe 3 now, that just recently changed it, that you can contact and say, I filled out my form, please give me a do not resuscitate bracelet, medallion, something like that. So that then when you're out in the community, if you're in a car accident, something happens, you fall, something happens, they can see your do not resuscitate EMS when they come. So those are the things, Jenny, have I covered? I know we're pretty close to time too. Oh, did we do organizing affairs? But they have them. Okay, great. Okay, so this next booklet, this is not an advanced directive, but we think this can really be helpful for people. This is this booklet called Organizing Affairs. Is great. It's really for after you've died and your loved ones, you know, it's a very stressful, grief-filled, emotional time. And if you have filled this book out for your loved ones, it can really provide them a lot of comfort. It has places for bank accounts and things, of course, that we've talked about today. They need
Had handled all of the finances and he died. She couldn't get into her bank account, she couldn't do anything for weeks and weeks, and she was just like dead in the water.
and she was already so grief stricken and already so emotional.
She
So,
got mad.
well, and then you get mad. Yeah. It's like, why didn't you leave me with this information? Yeah.
It's just like, it seems to me that these days of passwords where you used to be able to kind of like go to your printed copy of something, well, and you can't even do that anymore, and then you're stuck. So it's just really, really important. And
It really is. Thank you for that story because it shows like this happens a lot.
Smart woman.
Of course. Yeah.
Yeah.
Yeah. Yes, thank you. So this really is another gift you can give your loved ones by filling these things out. Yes.
Sorry, I'm a pest, but you're not these things, I'm not involved, but more and more, it would be nice if they included someone wishes for their pets.
So that's so interesting. I don't know, does this include pets? I will say that in the back of this, it does include like whether you want to be cremated or buried and where that burial or, do you have an agency already picked out if it has a plan? What kind of memorial service or funeral you want? Who do you want to speak at your funeral? Who should be called when I die? Who are the people I want called to notify them that I've died? So there's information like that in the back, I know, but I don't know about the pets.
We do have a group with Hospice Austin called Pets Peace of Mind. And it helps place pets that have from somebody who is dying. So that especially our fur baby may be our number one friend and family. So there is we have a specific branch that was funded by St. David's Foundation. Also called Pets Peace of Mind.
Thanks, Jenny. So this is a great book to give peace and also practicality. So the person isn't really angry if you haven't left their passwords. Can't get into those accounts that you need. So I think, okay, one more thing I'll ask you to do is the evaluation. So we have come to the end. I hope you have learned something. If you have, I would be really grateful if you would write in the comments. So there are some questions just to answer that are multiple choice. But then at the bottom, there's a section for comments. And I'd be really interested to know, as with the St. David's Foundation, are you going to take any action? What did you learn that was interesting that you didn't know before? Anything like that? What could we do better? What information would you have liked to hear that you didn't hear? So anything that could help us improve this would be welcome as well. So thank you all so much. So yes, I'm just gonna stand here silently while you take a few minutes to fill that out, and I think Johanna's on her way.
We got a wheelchair.
Okay.
Does anybody want to sign their directives or any other questions? What, Rick, you want to talk about the next program that we're coming up? I think that's probably. Talk to your doctor.
The next one is lunch, next Wednesday is lunch.
Here.
Wow, okay.
Oh, but I can. Thank you so much for joining us.
Thank
today.
you. I really appreciate it.
Next event is luncheon, our Wednesday luncheon next week. It'll be at the Age Building. Parking is always a problem, so try to carpool. There's plenty of people that'll give you a ride. And then the next actual program is on the 21st. And that's Dr. McCourse and I don't remember her name, a young concierge site doctor are gonna battle it out, what you should ask your doctor, how to ask your doctor questions. And that's going to be at Terrytown Methodist Church in the administration building. There's parking on the street, parking in the garage, and there's an elevator. So I encourage you to go to that.
And it's also online.
Both of these will be Zoomed also.
And the other thing is on our program, we also have a YouTube side. So you'll be able to go and to listen to this program again, as well as some of the other programs.
Well, we're posting them on our YouTube channel, including this one, right?
Yes, it will be. And thank you.
Thank you.
Thank you.
Yeah.